Hi, I'm Dom Sisti with the Department of Medical Ethics and Health Policy at the University of Pennsylvania, and I'm here with Dr. Jonathan Moreno, Professor of Medical Ethics and Health Policy. We're here today to talk about the Goldwater Rule, which was promulgated by the American Psychiatric Association in 1972 in response to a rather infamous episode in which several thousand psychiatrists were surveyed about the mental health and mental fitness of then presidential candidate Barry Goldwater. The Goldwater Rule bars psychiatrists from speculating or diagnosing individuals in the public domain as having a mental health condition or not. And it's been with us now for over 50 years. The last 18 months or so, we've seen quite a bit of controversy around the scope and the limits of the Goldwater Rule. So I'm here today to talk to Jonathan about the history of the rule and some of its ethical implications. Thanks for joining me today, Jonathan.
Thank you, Dom.
I'm curious first, just to start with the history of the rule. Were there other episodes in the history of psychiatry when psychiatrists, psychologists, and others speculated about the mental health status of a public figure?
Well, Freud himself did the psychoanalysis of a number of famous historical figures, but living people is a kind of a different story. And I think it's fair to say that became very important in a national security sense during the Second World War, when the father of personality theory, somebody named Henry Murray, who was a Harvard professor, was working for the CIA's predecessor, the Office for Strategic Services. And Murray did a famous top secret assessment of Adolf Hitler and predicted rightly that if Hitler was surrounded, he would commit suicide. What was different, of course, about the Goldwater episode is that this was not a foreign leader or the leader of an adversary, and not somebody who was deceased, but somebody who was alive, and very much a public figure. But I think what a lot of people miss about the Goldwater episode, looking back, so many decades later, is that it was this was a period when psychoanalysis was still very powerful, so that the psychiatric community was really dominated to the extent that there was a theory of psychiatry. It was before modern neuropsychiatry. Right. It was pretty dominated at a theoretical level by psychoanalysis. So the psychiatric community had a big stake in psychoanalysis and in protecting the tools of psychoanalysis from a bad odor. Mm-hmm. So when this kind of offbeat magazine called Fact, which was published by a very eccentric guy, decided to survey thousands of psychiatrists, the people that he was picking up were mostly people who used psychoanalysis in their medical practice, in their psychiatric practice, and had the psychoanalysis of the dead, in Freud's case, and the living very much on their minds. And then the results that he got is, was 1,189 psychiatrists, not psychologists, importantly, but psychiatrists, came back and volunteered the view that that Goldwater was psychiatrically inappropriate and to be president, that he was trigger happy, that he would be a threat to national security, that he might use the bomb. So that escalated from the point of view of professionals of the psychiatric community. It escalated the threat to psychoanalysis as a practice, in my view.
So let me just shift then to some questions around the normative grounding of the rule and ask you, aside from the risk to the reputation of psychiatry as a field and professional status, et cetera, what's the basic philosophical and ethical grounding for the Goldwater Rule?
I think it's as much, there is, first of all, the business of confidentiality, although if you've never met somebody, it's not as though you're disclosing any confidences. I think it's really an epistemological question that you should be, that that responsible medicine is medicine that involves actually seeing the patient in some way. And that's really only an idea, I think, that comes up in the last couple of hundred years. Right? I'm thinking about the shift that happened in the early 19th century about the doctor's physical relationship to the patient. Now I'm thinking about medicine, not about psychiatry, but the idea that you can actually learn something by touching the patient, by listening to the bowel sounds, or by feeling, what's going on in the patient's body. I think that's tied in somehow to the epistemology of medicine. And that you have to see the patient. The psychiatrist doesn't touch the patient, but in a way touches the patient emotionally. It's that encounter between the doctor and the patient. So that's the epistemology of the doctor-patient relationship and the ability to assess that then creates a sense of responsibility. And that, I think, it's a complicated connection, but I think that is the connection ultimately.
So psychiatry is different. And it seems to me one of the major differences is the power of the psychiatric diagnosis. It relegates an individual to a certain role in society, often stigmatizes individuals. Is that, you think, part of the equation for the Goldwater Rule?
Yes, and I think we had a nice test of that in the McGovern campaign in '72 when he had chosen a highly regarded senator, Thomas Eagleton from Missouri, to be his vice presidential nominee, his running mate. And then it came out that Eagleton had ECT, shock therapy, years before. Time magazine then published a cover image of Eagleton that was blurry, which brilliantly fed into the prejudice that people had about anybody who had depression and had ECT.
So over the last year and a half, the Goldwater Rule has come under some criticism, both within psychiatry and outside of psychiatry. One of the arguments I've heard is that psychiatrists are trained to recognize potentially dangerous, toxic, dangerous people, and they also have a duty to warn at times when they think that there's a threat posed by an individual. What do you think of that argument? How do you feel about its being used in the present day? I'm just curious.
Well, in practical terms, imagine that a group of senior psychiatrists, maybe former APA presidents or leaders of the profession, got together and they agreed that there was something really troubling about a president's behavior. What do? A back channel to the vice president's office. They read the 25th Amendment carefully. They see that it requires a majority of cabinet members and congressional involvement. I think they'd only get one bite at the apple, and I think it would have to be done with utmost discretion. So again, we wouldn't hear about it, or one hopes we wouldn't, until the matter was resolved. So in practical terms, I think there's a good argument that there's a professional responsibility. On the other hand, if the matter is that gross, it shouldn't only be obvious to people who are in psychiatry. Psychiatrists are presumably trained to do more subtle, nuanced assessments of personality and disorders than you and I are. So if it gets to that point, then we should be well beyond a failure of the political system to respond to the crisis.
Yeah, that makes a lot of sense. You don't necessarily need to be a clinician to see dangerousness when it's that obvious. And
by the same token, what is a dangerous pattern of behavior in, say, diplomatic matters may not be behaviors that a psychiatrist is necessarily trained to recognize.
Yeah, right.
So
it's hard enough to recognize dangerousness in behaviors that they are trained to recognize,
Indeed.
Let alone things that they're not trained to recognize.
Yes.
That makes good sense. So, Jonathan, thanks for your time and expertise on this matter.
Thank you.